So today is day 2 of the summit, and again, we'll begin with a land acknowledgement today. We are grateful for the opportunity to gather virtually on this land and thank the generations of Indigenous people who have taken care of this land long before other nation groups came. We acknowledge that the work of CASSA takes place on traditional Indigenous territory of the Huron-Wendat, the Haudenosaunee, and the territory of the Mississaugas of the Credit. This territory is part of the excuse me, Dish with One Spoon Treaty, an agreement between the Anishinaabe, the Haudenosaunee, and the allied nations to peaceably share and care for the resources around the Great Lakes. This territory is also covered by the Upper Canada Treaties. Today, see Tekaronto, the traditional Mohawk name of this area called Toronto, meaning trees in the water, and its surrounding areas are still home to Indigenous people, and we are grateful for the opportunity to meet, work, and play on this territory as settlers. We wish to express gratitude to Mother Earth for the resources we are using and honor all the First Nation, Métis, and Inuit people who have been living on this land since time immemorial. This recognition of contributions and historic importance of Indigenous people must also be clearly and overtly connected to our collective commitment to make the promise and challenge of truth and reconciliation real in our communities. As today's session focuses on health equity once again, it is particularly important for us to recognize the severity of health inequities in Indigenous communities. We stand in solidarity with Indigenous communities in calls to all levels of government to develop Indigenous-led health policies and practices that are informed by Indigenous healing practices. We must hold our government and health institutions accountable and advocate for increasing equitable access to healthcare for Indigenous people. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the health and well-being of Indigenous communities. And as I mentioned yesterday, I encourage everyone at this session to actively seek information and take action, especially as we recognize the upcoming National Day of Truth and Reconciliation on September 30th. And a little bit about CASSA for those of you that are not acquainted with our organization, or if this is your first CASSA event. So CASSA is a not-for-profit social justice umbrella organization. We represent over 120 member agencies across the province, generally concentrated around the Greater Toronto area. However, over the last couple of years, we have been doing some national work, especially around anti-racism and anti-hate, gender-based violence. So we are expanding as an organization. We aim to build a capacity of South Asian communities to be able to participate fully in political, economic, social, and cultural fabric of Canadian society. Our focus is on advocacy, training, and capacity building and policy change. And our current strategic directions include health equity, reducing poverty, supporting immigration and settlement, strengthening gender equity, and building an anti-racist and anti-oppressive Ontario. So this summit, as I mentioned yesterday, it's been something that we've been doing for over the last decade. We've had 9 summits in the past, and we've been engaged in health equity for longer than that. The objective of the summits is to allow South Asian and other racialized communities to discuss how we can work together to influence strategic system level changes, which will improve health outcomes for our communities. Last year, the focus of the summit was on the beginning phases of COVID-19, care and response. And this year, we're continuing this conversation and focusing on concerns of the reopening process. Today, we have a whole new set of speakers and experts that have been doing work in this field for a very long time, and advocates that are working day and night to advocate for their community. So we have Angela Robertson, Dr. Amrita Mishra, Dr. Amit Arya, Dr. Amrit Sadev, Samia Abdi, Sabina Vora Miller, and Noshin Hussain. The plenary speakers will lead discussions on stigma, discrimination, violence, and human rights, as well as building resilience for future public health crises. While the breakout speakers will lead discussions on data collection and decision-making, effective communication strategies, and a framework for community engagement. Through this summit, we demonstrate our collective capacity to improve health equity in ongoing and future public health crises. A couple of details about Feedloop. I know that yesterday, the people that were here, by the end of the day, they were able to kind of manage and know the system a little bit better, and hop from one session to another, and do some networking. But just to highlight some of these instructions once again. So throughout the summit, you'll have the chance to connect with other attendees and speakers in a variety of ways. You can connect with attendees using the summit-wide chat feature in the lobby area. So as soon as you log into the platform, you are in the lobby area, and you can see all the attendees on the right panel. You can see their titles and their names, and you can engage in one-on-one chat with those attendees. And if you look on your left side, there's another panel, and it has different areas that you can go to. So lobby, the sessions are there. So session is where you will want to go in order to see all of the content for the event. You will have access to the live webinar and additional information about each session, such as the speakers, the description, or any other relevant files. I believe we'll also be, if the speakers give us permission, we will be posting their PowerPoint slides or any other materials that they want attendees to have, given that we have their permission. To view the full screen, you click view and then full screen at the top right corner of the video player that's on right now on Feedloop. You can also engage in live question and answer using the video player's chat feature. So it's very much like normal Zoom once you're in the video feature. You know, the chat, the participants, you can do all of that like you would do normally with Zoom. The only difference is if you want to engage in other parts of the summit, like networking and connecting with speakers, then those features are obviously available as well through Feedloop. In the account area, so if you haven't done so already, please feel free to complete your profile. You can connect your social media accounts. You can upload any documents that you would like to share with other attendees. And in the networking area under the people tab, you can search through attendees and speakers to view their profile and again, initiate the one-on-one conversations. And we encourage people to do that during the lunch half an hour break that we had yesterday, and we'll do the same today. Notifications will appear on the right-hand corner of every page that will alert you of any chat notifications and important announcements from the summit organizers. If you are experiencing any trouble or any IT issues, you can connect with the event admin. So that's Madiba, using the private chat feature. You can find instructions that I just outlined in the help tab on the left-hand side of the website of Feedloop. So again, don't forget to share your thoughts and your excitement about the summit on social media, and whatever you've learned, things that you want to take away from the individual sessions. Remember to tag our Twitter, our Facebook, and our Instagram handle, which is CASSA Online, and use the hashtags 2021 Health Equity Summit and CASSA Health Equity Summit. And you can see in the lobby, those anything that you post will be on the social wall that's in the lobby. I also want to make note that the summit will be recorded, as you probably heard at the beginning of this talk here, and the recorded version of the summit will be available to stream on YouTube. I would also like all the attendees, if you could please, once you join the session, if you could put yourself on mute if you are not presenting, that would really help our speakers concentrate and really deliver a quality presentation. And just like yesterday, at the end of the session, there will be a pop-up for a feedback survey. We really appreciate if you could really fill out that survey, be honest with it so that we can improve any future events that we do here at CASSA. So without further ado, I promise this is the most I will be talking today. We will head to our first plenary sessions. So the first session is from Angela Robertson. So it's my great pleasure. I've had the pleasure of working with Angela on different tables and different advisory groups, and I'm really excited for her being with us today and taking the time out. I know it's a very busy time for all of our speakers, and we really greatly appreciate their willingness to come and speak at our summit. Angela Robertson is the executive director of the Parkdale Queen West Community Health Center. Parkdale Queen West is a community-based health service organization serving Mid and West Toronto. Angela is dedicated to people and communities facing discrimination, poverty, and marginalization, and working to change those social conditions. She is a founding member of the Blockorama, which focuses on forging spaces for Black and other racialized LGBTQ people and allies in Toronto's Pride, and has served on numerous community boards, including Black Coalition for AIDS Prevention, HouseLink, and the Stephen Lewis Foundation. Angela has been recognized for her social justice work by YWCA, Fred Victor Center, and an Urban Alliance on Race Relations, Now Magazine, and was honored by York University in 2017 with an honorary doctorate of laws degree for her social work. In response to the impact of COVID-19 pandemic on racialized and low-income populations, Angela initiated and co-chaired a Black Health Equity Working Group of health sector experts, leaders, and practitioners and researchers concerned with improving the health and well-being of Black people. For her work, she was recognized by the Alliance with the Denise Brooks Equity Champion Award and the Pillar of the Pandemic Recognition Award from the U of T's Dalla Lana School of Public Health. Angela will seek to identify strategies and actions that can advance actions for equitable access and outcomes for Black, racialized, and low-income populations. Over to you, Angela.
So thank you very much, and good to be in the room with a lot of familiar folks, and I see names of people who have contributed to this collective effort and work. I framed my comments as moving beyond solidarity statements, actions for change, and clearly better outcomes. Because I think what we have seen in the last 18 plus months is we have seen lots of, and even before, we have seen lots of commitments, and just coming out of the recent election, we have seen significant statements and promises made. And I think that collectively now and individually is we need to now move and push for accountabilities beyond those platitudes and statements to ensure that recovery for communities really mean substantive action and response to the sites of structural inequalities and structural racism that many of us have experienced and continue to experience in this pandemic. So in terms of framing a little bit around what are some of the things that we have seen in the pandemic. The pandemic was called March 11th, 2020. And what we have seen since then are a few things. So we saw higher rates of COVID among racialized populations. And you will recall that we identified that here in Toronto with the Toronto Public Health data analysis, but then we also saw that being echoed by our Chief Public Health Officer, Teresa Tam, who identified that 80% of COVID cases have thus far occurred in people who identify as racialized. And that's many of us and many of the communities that we come from as folks who are in this room. What we've also seen is higher rates of hospitalization among racialized populations. So when compared to white populations, we have seen higher rates of hospitalization among racialized populations, Black populations, specifically as well in terms of some of the data has identified. I think the other thing that we have seen in COVID is that when vaccines were being rolled out, so in the early April, when the vaccine rollout started in long-term care homes, and that was the moment when we saw vaccine scarcity. So there were production line and supply chain issues with the vaccine production. So during that period, what we saw and after, what we saw that in geographies and spaces where we live, where larger numbers of racialized populations live, where there were higher rates of COVID in terms of COVID infection is that those areas saw lower rates of immunization. So in a moment of scarcity, when there were places identified as having higher needs and higher vulnerabilities because of some of the comorbidities that those communities experience. So comorbidities including health conditions, but also the social deprivation around issues of poverty, issues of housing, issues of social supports, access to healthcare, is that those populations were denied, I would say, the vaccine at the same rate as, and we saw specifically that, and this was identified, this is not manufactured information, this is information that the ICS data revealed in April 2020, that there was a significant differential between sites and geographies of high COVID rates, high rates of racialization, high rates of social deprivation, and lower rates of immunization. So, and then what we also saw conversely as well is that when communities mobilized and vaccines were brought to those communities in an accessible, responsive, and culturally responsive way, grounded in supporting the use of ambassadors, the use of immunization teams that reflected the community and that could speak to the community sites of hesitancy, is we saw that there was an uptake in vaccine access. So there was a little bit of a flying in the face around the sites of vaccine hesitancy and the unshackling of the perception that our communities are anti-vax communities, or communities are communities where there is sometimes healthy mistrust, healthy hesitancy, but we know some of that is rooted in the experiences of discrimination that many of us have experienced inside of the healthcare system, and that there needs to be a twinning in addressing that while we do education around vaccine hesitancy. I think lastly, the other thing that we saw during the pandemic, and we continue to see, is many of us have been long calling for the collection of race and socio-demographic data. And I know that CASSA is an organization that has been linked with the color of poverty, color of change, asking for the same very long pre-pandemic. In pandemic, what we did here is the Ontario medical officer identified that when we said we need to collect race-based data around COVID rates of infection and in COVID testing, what was identified is that, well, there really was no need to do that because all populations would get equal access and would be impacted in the same way. And therefore, there was no need for Ontario to collect race-based data. And in fact, what we have seen is, as I said from the other data identified earlier, is we've seen exactly the opposite. So the pressure and the call for race-based data, I think, is one that is significant. I know that Corey and others in, I think, a panel yesterday discussed that. And I think there's a plenary coming up later, I think, that will pick that up. But suggesting that we need to continue to push for the data collection, but that the data collection, so when we talk about actions for future change, is that the data collection must be twinned with action strategies, is that having the data alone is not the change we seek. We seek to have the data and we seek to have it twinned with actions for change, because we have seen our partner and the US, they have significant data sets about the sites of inequality for racialized population, but they have not changed the trajectory by having data alone, because that has not been twinned with actions for change. So, and the other piece that I think we must also push for in this recovery is that our communities are involved in the analysis of what that data is telling us, and therefore what the recommendations and strategies for change must be. Because we know that you can have the data, you can have an analysis, you can have an action for change, but if the communities who are most impacted and their voices are not part of that planning, is then the outcomes and the strategies that get developed are oftentimes not responsive to our needs. I think in terms of going back to then the comment about if this is what COVID has magnified, is the other thing that has also been magnified and spotlighted in COVID is the real unmasking of racism, of anti-Black racism, anti-Indigenous racism, anti-Asian racism in COVID. So we saw with the murder of George Floyd, that was, you know, for the nations and nations to see, is that coming out of that, we've seen a number of institutions rushing to make statements of solidarity, including governments, but we have not necessarily seen actions for change. So when so moving to, in terms of speaking to a little bit about actions for change, and we can pick this up in the Q&A section, is that the acknowledgement of racism in and of itself is a starting place. But again, we need to have actions, and we need to have actions that are not just embedded in small initiatives off to the side, but as the government seek to lift up recovery strategies, is that the recovery strategies must embed anti-racism initiatives and efforts to address what we call structural inequality and structural racism. So for example, as we see new governments now about to lift up economic strategies for recovery, is that in those economic strategies, we need to ensure that the wage enhancements that were made and the declarations that were made during COVID that identified essential workers as an important pillar in a pandemic and in a health system response. And in COVID, we saw that they were given some wage enhancements. We need to see that in the recovery strategy moving forward, that those responses in COVID continue to be sustained in recovery. So we need to ensure that recovery, that essential workers remain essential in the economic plans, and that there are wage enhancements that are embedded for this group of workers. The other piece in recovery strategy that we need to ensure is, I say that affordable housing strategy is an anti-racist response, because we know that where large numbers of racialized low-income people live, is that there is housing insecurity and housing precarity. In the pandemic, we saw a moratorium on eviction. As we're coming into recovery, we're seeing that moratorium lifted, and we're seeing significant numbers of racialized families now in front of the tribunal threatened with homelessness. So I really believe that when we think about recovery, we need to also think about things like housing and what that means for us and our communities, and therefore pushing for a real affordable housing strategy and housing development strategy, because we know that our communities will benefit. The other piece that I think is important in the recovery effort is, during the pandemic, we saw significant rates increase in the experiences of violence against women, and those seeking refuge, and or those who were experiencing violence but were silenced because of the isolation and divorced from access to services. So in a pandemic recovery, we also need to bring a gendered analysis and a gendered lens to the recovery strategy that will benefit us and racialized, in terms of communities of women. Because we know that, and that there was just revealed that racialized women earn lower than their white counterparts doing the same work. So we know that there is not just a gender gap in wage, but there's also a racialized gender gap in wage analysis. And I will, you will have to tell me my time there as well. The other piece that I will speak to as well is overdose response. So we're talking about stigma and mental health. And what we've seen in COVID is we've seen that over almost 2,500 individuals in Ontario died of an overdose. And therefore, and at the same time, we have seen a decriminalization of efforts being moved forward around decriminalization for in terms of personal use, and we've seen the decriminalization issues attached to cannabis. What we have not seen, however, is we have not seen a twinned strategy that brings what I call addressing how the war on drugs have differentially impacted racialized populations, Black, Indigenous, and other racialized populations. And therefore, as we talk about overdose response, as we talk about treatment, as we talk about access and harm reduction, is that we need to bring a race lens and a race analysis to the harm reduction strategies, because we know that it's racialized populations that have been largely criminalized and differentially criminalized in this moment. And I would say then, in terms of lastly, when we think about COVID and its impact, is I think we need to think about a public health response and identifying. We know that racism has been identified by the Public Health Association of Canada as a public health issue. And therefore, if racism has been identified as a public health issue, then we need to ensure that the strategies that are enabled are strategies that lift up a public health response to racism that brings a population health strategy. And happy to have further conversations as I see my chat tells me that I am just out of time. So looking forward to the conversation. Thank you.
Awesome. Great. Thank you so much for that, Angela, and for that insight on a lot of the issues that a lot of agencies were facing and a lot of communities were facing from the start of the pandemic, and a lot of that advocacy. I know everyone in the room is really appreciative of everything that you have done and in the coalitions that you're part of to get to where we are. And I know we have a long way to go, but really appreciate your remarks. We have a few minutes for Q&A. So if anybody has any questions for Angela on anything that she talked about today, you can ask either by unmuting your mic or you can post your questions in the chat.
And if there are no questions, sorry, did I hear?
Yeah, go ahead.
Yeah, and if there are no questions, the one piece that I would also want to just frame as well is the need for deliberate sites of solidarity and actions between Black, South Asian, and Indigenous populations. Because we know that as folks who have come here as migrants and or immigrants in generations present or past, is that there are ways in which racism also lifts up division among racialized populations that frames who as more preferred than not. And therefore, it puts many of us in competition and forces either competition for what is called scarce resource, and or it pushes us and systems pushes us around the model minorities and the framing of different groups of immigrants and racialized populations as the model minorities. And I think we need to interrupt that by being very much more in communion and in solidarity around advancing strategies that may be population specific. So I may need to be particularly in solidarity and explicitly so with South Asian populations' demand for certain sets of demands, and equally then conversely South Asian populations being in solidarity explicitly with Black populations' demands for certain redresses, so that that divide doesn't exist. I see a question I see two questions in the chat there.
Let me just read that out
Yeah.
loud for you. So thanks for your brilliance, Angela. Wondering if you have any reflections on the push for decriminalization of drugs within Toronto, and how to rally folks who haven't been so involved in harm reduction work can better support folks who use drugs.
So there is the Toronto Public Health just launched a working group around decriminalization of drugs for personal use. And there is currently a survey that they have deployed. It's on their website, and I can send that later to Samia for distribution to the group. And I think it would be important for us to get that survey out to our community networks, but with some background around what are some of the perspectives that our communities should bring forward, particularly around the differential impact of criminalization on racialized populations, and then what is needed. So I think one is being involved in those conversations and those feedback loop. I think two as well is, so this conversation is about stigma and discrimination. It's also about us having conversations internally with our communities around lifting up the presence of stigma around substance use, and how that keeps us from supports, from harm reduction supports. And because we know that some of that stigma is also twinned with racism. So we know that as populations, as communities who are pressed up against racism, is therefore we are sometimes reluctant to pick up yet another issue that brings further stigma, and substance use is one of those issues that bring further stigma. And therefore sometimes our communities are silent and or push back against folks in our communities who need support because they're substance using. So I think we need to also have that conversation about how racism keeps us silent and therefore keeps us away from bringing supports to our community members who are living with and dealing with substance use issues.
Great, thank you for that. There's a comment and a question. So the comment is around the vaccine sites and how there was, it was very inaccessible at the beginning, and there was long lineups in postal codes, especially where there was low-income populations and racialized populations. So that's a comment. And this question from Michael Kerr is one of the tried and true strategies of governments, as well as the current holders of power and privileges, to divide and conquer, as you mentioned, around the horizontal violence between racialized communities, to undermine efforts to bring about real systemic change. How do we preempt and work against their efforts to play to specific groups and pander to select communities?
I think we're in this perfect moment, which is this minority government and this post-election event, because governments will know, because we have a minority situation, because we also have a moment in this in Ontario where we will be going to the polls at some point soon, and we will also see the same at the municipal levels as well. I think that this is a moment where there is an opportunity for, I think, great collaboration across the various associations. So I think that there is a good opportunity for CASSA, for the Black Health Alliance, for the networks of organizations that are responsive to the needs and or creating strategies for racialized populations to come together to build some common approaches and frameworks. So it's a unified approach that is being brought forward that lifts up each other's strategies, because we know that the issue, you know, the roots of racism, they come from the same tree. So the way they manifest may look different for different groups of racialized people, but they're all coming from that same source. And therefore, if if collectively, and so this is a volley to CASSA, if there is an opportunity to really bring a bit of a common, almost a little bit of a summit together with the other associations to bring some common in terms of asks that lift each other's strategy up, is I think we would be certainly further ahead. And it then undermines the effort of the political elected leaders to try to do the cherry picking off with us against each other. And the small offerings that they bring, which is we'll give you a couple of million here for your community, and we'll give you a couple of million here for your community. And how long have we been getting these small millions and millions, but the roots and the substantive changes have not occurred, and the social conditions still remains the same.
Thank you so much, Angela. Really essential points made here, and definitely going to take up on your volley. And we've actually been closely connected with a lot of the different communities doing strategy work, including Black Health Alliance and including the Black Health Equity Working Group. And we are in the works. We've applied for a Public Health Agency of Canada funding to do some collective strategy and collective organizing and collective community consultations to see what are our kind of common needs. And obviously there are specific needs to our communities as well. And we want to put this work forward. It's been in the works since pre-pandemic, but really, and I really appreciate that this is the time and this is the opportunity window that we have to really push this. So going to connect with you afterwards for this as well. There is another question, but unfortunately we are out of time. But if we have, if Jackie, you want to connect with Angela during the networking session on one-on-one, it's a really great question about global equity for vaccine engagement and delivery of vaccines to communities that are not necessarily in countries in North America and Europe. So definitely a great question, and maybe we can engage with that afterwards. So unfortunately, we will have to move to the next speaker just to stay on time. So our next speaker is Dr. Amrita Mishra, and she will continue to speak on the stigma, discrimination, violence, and human rights. And maybe Dr. Mishra, if you want to touch on that, if I'm not sure if that's included in your presentation, but maybe we can talk about that in the Q&A. Dr. Mishra is an action researcher and capacity builder at the Indo-Canadian Women's Association in Edmonton, where she develops evidence-based tools, service models against gender violence. She volunteers on federal and provincial advisory committees on immigration, health, gender equity, and diversity and inclusion. As an academic researcher, Amrita has researched and published on HPV immunization policy and practice, platforms for improved resource sharing and collaborations in genomics, history of cervical cancer screening, and power authority configurations in science labs. Amrita is also a blogger on social justice issues, polyglot, boxer, graphic designer, and avid reader. Dr. Mishra will explore the role of healthcare providers in the provision of culturally safe, sensitive, and compassionate support to patients who are living with family violence and or intimate partner violence. Please welcome Dr. Mishra to the stage.
All right, thank you very much for being here today. And I work with the Indo-Canadian Women's Association in Edmonton, and our mandate and mission are extremely similar to CASSA's by a wonderful coincidence. And what I'm going to talk about today is an extremely complex topic on gender violence amidst the pandemic, and what healthcare providers can do, not just within the pandemic, but in general, and how they can apply an approach of cultural safety in handling what I see as a global health crisis. I'll explain the concept of cultural safety later on down the line. Given the complexity of the topic and the time constraints, I can only do this talk in broad brushstrokes. And I'm very grateful to Angela Robertson, who has actually touched upon the intricacies before I get into this, which saves a lot of time. And if I miss out stuff, which I will, she has already covered it. I live and work on Treaty 6 territory, for which I render my gratitude. Amisk Watsi Waska Waskahikan, meaning Beaver Hills House, aka Edmonton, is located within Treaty 6 territory and within the Métis homelands. I acknowledge this land as the traditional territories of many First Nations who have come before us and who have suffered extreme discrimination and racism in this province and across the country as well. It is important to make this acknowledgement not just as a pro forma acknowledgement, as we have heard time and time again, but to understand the colonial history of this country and to link it to a concept that I use in this presentation, cultural safety, which has come from Indigenous healthcare. I have no conflict of interest in making this presentation. I have no financial interest in the material or the case examples. All data is from openly accessible public domain sources. To the extent possible, I have provided links and citation data. My talk is organized in 4 sections. First, I would like to consider gender-based violence, GBV, hereafter as a pandemic. What healthcare providers can do against gender violence, not just within the pandemic, but overall. What is cultural safety and how can it be applied to do any meaningful work against gender-based violence in the healthcare sector? And last, I would like to look at a model where culturally safe and trauma-informed support against gender violence has been implemented in a hospital context. The Dilasa model is not from Canada. It actually comes from India, from Mumbai. The reason I chose this model is because it has been successfully applied in a context which is resource constrained and marked by extreme patriarchalism. And yet it has been successful, and so I think we have something to learn from that. There are appendices as well, which I will not get into. There are many slides that I will not discuss in detail. They just provided as background reference. And since the organizers will provide the slide deck after this talk, you all have access to those slides as well. Gender-based violence has been called a shadow pandemic, and it's a global health problem, a global public health problem. It's not just family violence. It's often conflated with just family violence or, interpartner violence, but it includes many different forms of violence. It includes, for example, sexual trafficking. Racism converges with gender-based violence. We have seen that time and time again, and several other forms. But it is a global health problem. And during the last 2 years, it has become clear that the new pandemic with which we are all coping has successfully colluded with another much older pandemic. And it's not really thought of as a pandemic. It's thought of as a family problem, relational problem, interpersonal, behavioral, legal, or economic problem, or law enforcement issue. What it is all of those, yes, but it is much more than that. It's a public health crisis of global proportions. And unlike COVID-19 or H1N1 or other pandemics or epidemics, it has been around, sustained by structural social factors for a very long time. Now, the escalated gender violence of COVID-19 is not really a surprise to people who study pandemics and epidemics. Spikes in gender violence have been seen in earlier epidemics and pandemics and after natural disasters as well. And measures to prevent infection are ironically facilitators of violence. There are many facilitators. We all know about the effects of isolation, staying home, staying away from work in places of respite and support. The multiplied burdens of working from home and working in the home, because women have multiple jobs outside the home and inside the home. The effects of economic precarity and homelessness and housing precarity. Loss of access to services that might have made a difference. Angela Robertson touched upon this. There's something else I want to talk about. There's been a lot of focus on virtual interventions against violence for health during the pandemic. Now it's great. We are all on Zoom. We can connect with Zoom, but what about those who can't? What about the seniors who don't know how to access Zoom? What about the lack of connectivity in rural areas? What about women who don't have the data minutes or the equipment? What about if their Wi-Fi password, for example, is in the hands and controlled by the person who's subjecting them to abuse and isolation? Now, in Alberta, the picture has been pretty grim. I mean, COVID-19 has been especially grim in Alberta if you've been following the news. And the headlines, I think, that I presented here speak for themselves. Emergency protection orders. So EPO orders shot up during the pandemic. And it's of interest because EPO reviews were among the few court matters that were not postponed during the spring 2020 COVID restrictions. Domestic violence calls to police shot up, but the Alberta shelters didn't have a proportional intake. And this is because people were sheltering at home. That's assuming they had a home. Many assumed that the shelters were shut. And in many cases, shelters stopped taking in people because of COVID-19 restrictions. So there's this wonderful report that came out. It surveyed providers of anti-violence services across the country. The reference is below. And what was made clear was that on the one hand, people could not access services. But on the other hand, the anti-violence sector has traditionally been overburdened and subject to short-term funding. We all know that problem. And things got worse. These are some of the quotations from that report. The last one, working for survivors of sexual abuse, you hear a lot of horrible stories every day. And since COVID hit, I had to invite those stories into my home. When people started working from home in the anti-violence sector and work-life boundaries started breaking down, trauma started entering the home. And we still don't yet know what happens in that because many people in the anti-violence sector are immigrants themselves, coping with a lot of trauma, a lot of abuse, and a lot of violence within the home, and they're working in the anti-violence sector. So I invite you to think about the convergence of what that does to them. There's a StatsCan report, which also describes and provides exact data on what happened. So the most common factors impacting service delivery were accessing resources for clients and the shifting of staff to working from home. Now, volunteerism was greatly affected. Now, the nonprofit sector has traditionally depended a lot on volunteers, and that was hit very badly. And because we are perennially short on funding, that cut back even more on our resources. So this is a graph showing what was covered in that StatsCan report. I won't get into it, but you're welcome to look at it when the slides are shared. This, again, I won't get into, but this provides a wonderful across the world data report on what community serving organizations and women's rights organizations report from around the world, and it's a report by UN Women. It's a long and very rich report, very good reading. I encourage everyone to access the PDF. A lot of the pictures that I have in the slide deck are hyperlinked. The PDFs are all there. You can see that and find them. Now, I hear a lot of talk about building back better, and the cynical side of me thinks that we can build back or we can build better, because returning to normal is not going to return us to a great normal. And I want to point you out to the third quotation on the right side. Government officials need to acknowledge the connection between social factors like socioeconomic status, race, age, etc., and domestic violence. How can we shift our services to online if we acknowledge that many women in these horrific circumstances most likely live in poverty? And the quotations from this report also describe the short-term funding. As long as we operate in a neoliberal landscape and we have the short-term funding and we have the perpetual reproduction of the problems that we are supposed to cope with, there are no long-term and sustainable solutions. So building back is not an option. Building better, there's a lot of pie in the sky promises out there, but frankly speaking, what's going to happen after the pandemic is over and memories fade? I don't know. That's just my inner cynic talking. So there's this report by the Violence Against Women Learning Network, and two of the things that they emphasize are health system responses should ensure access to safe spaces and support resources. They talk about enhancing access to referral pathways, strengthening access to referral pathways, recognizing intersectionality and integrating intersectionality and anti-oppressive practices into GBV services that are integrated with health services. This is a great report, and it says some things that are extremely pertinent to the matter I'm talking about. And this brings me to cultural safety. What exactly is cultural safety and how does it bear on anti-violence service? What healthcare providers can do against gender-based violence, including but not only intimate partner violence and family violence. Now, there's no shortage of tools for healthcare providers to do family violence screening in a clinical environment. 3 tools for periodic use, longitudinal use during obstetric visits are radar, HITS, and AAS. The details of those 3 tools are described in that report by the article by the authors below, Deshpande and Lewis O'Connor. You can access that through the PDF. The main thing to note here is that all the tools are meant to be used in a longitudinal way. That means repeated contact. Pregnancy, it's a 9-month process. So it's repeated contact between healthcare providers and the client. And this gives a unique opportunity to develop trust and rapport. And trust and rapport are just not nice, fuzzy, feel-good things to have. They're essential to the process of screening and getting some valid information. So just having the tools is okay. It's not enough. Tools need to be used in the right way at the right time. That means not only technical competence, but also social competence. How do you create trust and rapport so that the screening tool can enable candid responses and not false negatives? Trust is a must for the longitudinal use of these screening tools. An approach in which trust and rapport are welded to technical competence and cultural safety. Why? Because you're going to be talking about abuse and violence with a person who is in tremendous pain and already traumatized, who can be re-traumatized through on-the-nose questioning, who may not be able to speak because of incapacity, shame, fear, hesitation, trauma. For all those reasons, cultural safety and understanding what that means is a must. A significant and disturbing number of reports have found gaps in the level of knowledge and training about these three aspects: causes, signs, patterns, and consequences of gender family violence, complex challenges and needs of marginalized and disempowered populations, and concepts and practices of cultural safety amongst medical students and healthcare service providers in Canada and elsewhere. Now, from the practitioner's perspective, training and experience in using screening tools has professional benefits, helps them feel better prepared, more comfortable having the conversations, and so on. What about the patient's perspective? When you start foregrounding the patient's perspective, you start talking about cultural safety, because this takes and privileges the perspective of the person receiving care, first of all. Before discussing cultural safety, I want to talk about what its absence can do. Some of you may have read of the case of Brian Sinclair and his unfortunate death in an emergency department, where he was literally ignored to death while he waited for care in his wheelchair, has been written about and has been reported. The reports are all there. The picture is hyperlinked. I encourage everyone to access this and read it, because this has been a turning point in the conversations of cultural safety in this country. Cultural safety comes from the experiences of Indigenous people accessing, for lack of a better word, healthcare, and how racism, medical racism, plays out in the healthcare context. This is a small vignette of what a lack of cultural safety also looks like. In a therapeutic context, an Indigenous woman who is trying to talk about her experience is shut down. Now, cultural safety in providing care involves understanding the barriers that impact access to care. The concept has come from transcultural nursing and Indigenous healthcare from the work of Dr. Iriapeti Ramsden in New Zealand. Why is it crucial? Racism, misogyny, cis-centric heterosexism, these operate on a pandemic level of strength, and healthcare providers are not immune. None of us are. That's why it's crucial that all service providers, all care providers critically appraise their work for cultural safety or lack thereof. Understand cultural safety or what its lack mean. How do power and privilege inflect our work? Whether it's a choice of terminology, do we use fancy jargonated language to a person who's already feeling very threatened maybe because of a language barrier, maybe just being terrified in the clinical context? Could it be a tone of voice, a command and control tone of voice? Like, I'll let you fill out this form. It's threatening, obnoxious, and offensive. It could be a referral process. Do you support the person through the referral process, or do you just shunt them out and onwards to the next pillar and the next post? All of these things should be understood and then operationalized into service. Now, in this process, it's not like cultural competency where you can develop a checklist of desirable attributes. There's no pass-fail for being culturally safe. What you're talking about is process and experience. And that's the experience of the recipient of care. That's what matters. Won't get into this report, but I encourage everyone to read it because it talks about systemic racism in BC healthcare. Fantastic report. All the links are down there. The picture at the bottom right is of Joyce Echaquan, and all of you may have read what happened to her and how she documented her last moments in a Quebec healthcare facility. Do providers know the term cultural safety? Some do, some don't. Do they get that it has nothing to do with cultural competence or awareness? Some do, some don't. Cultural safety refers to the dynamics, mechanics, and forensics of power in giving and receiving service. Attention to the structural inequities that afflict distressed clients. It does not have anything to do with cultural cosmetics. A mom with visible and hidden injuries and two small kids does not care if I say namaste to her or not. It's nice, it breaks the ice, sure, but what really matters to her is if I can help her get through a horribly complicated service landscape, if I can use my language skills to advocate for her and seek her permission in safely interpreting for her. What we need across the board is consistent training, understanding, and application of cultural safety, which is misunderstood, muddled with cultural competence, and is seen as fluffy, feel good, and dispensable, not really the real work of care. People resist talking about their own power and privilege, how it enters their work, they're unconscious of it, they resist talking about racism and sexism, difficult conversation that no one wants to have. Sure, they'll talk about it in broad terms, but they won't talk about it in a way that's operational. Until something entirely awful and preventable, like what happened with Joyce Echaquan, like what happened with Brian Sinclair happens. Cultural safety has clinical ramifications. Properly applied, it can save lives. Not applied, it can kill. Now I want to come to the DILASA model, which I said I would talk about. It's one successfully applied model of culturally safe practice from the South Asian context. DILASA is a program run by Sehat, a Mumbai-based NGO. It's a replicable and successfully replicated model of feminist, trauma-informed, and culturally safe hospital-based support against gender violence from India. I've just provided the link to that organization. They have wonderful research and report that combine advocacy, research, and operations, very similar to what CASSA does, applied in a hospital context. Really worth a visit from a context which is highly patriarchal, highly resource constrained. For work like this to be done, I think it's an example of a best practice from a part of the world from which very little is expected and which has actually managed to make a go of it. In the DILASA model, the hospital becomes a crucial catchment area for strategic and compassionate reach out to young women. The three yellow circles, if you notice them, DILASA means reassurance. The placement and signage signal and enable safety, relevance, and accessibility for women who need it. The counseling is located next to the outpatient department and is near the OB-GYN section as well. So the referral can take place from those sections. Staff are trained to identify red flags. Burn wounds that's hyperlinked because it leads to an article on PubMed. Burn wounds are often a sign of gender violence in the Indian context. Sehat has actually trained hospital staff to consider gender violence through a gender lens, understand gender violence is affecting a woman's health, and also to take on the task of intervening when necessary. And they have integrated counseling and training with the medical residency as well. I won't get into all of this. This provides details of the feminist counseling through the DILASA model. One of the key aspects is the integration of the compiling of evidence for legal cases between doctors, law enforcement, and the counselors and the survivors. Sometimes women just want to be heard. They don't want to come out and, just get drawn into a cascade of further violence. So counselors understand they shouldn't try to be fixers-uppers. And even in that resource-constrained context, even within COVID, they work with women to try to provide shelter for up to 48 hours. It's really resource-constrained over there. The success of the DILASA model has led to its scaling up. It has some institutional stability now, and it has been recognized as a best practice, and there's a lot of published research on it. I want to thank you all for listening. I want to thank the brave survivors I have met who shared the stories with me. Thank you to our funders and to my colleagues at ICWA Edmonton. Welcome your questions.
Thank you so much, Dr. Amrita Mishra, for that powerful presentation, and really appreciate you bringing in so many different examples and best practices for us. And really highlighting some of the struggles in the field of gender-based violence, especially during the pandemic. And we do have an ongoing project that we are trying to explore. So we know that I know that I've already asked one of my staff to connect with you afterwards about that. So we maybe we'll have one question from Rita because we are out of time for this particular session. But again, if there are any additional questions and if Amrita will allow, audience can connect with speakers one-on-one and have their answers, have their questions answered. So we have time for one question. So there's a comment. I love the example of the hurting mom who doesn't appreciate or need to hear white people say they like Bollywood star or curry. Any
Thank you.
questions for Dr. Mishra?
If there are no questions now, Samia and Mediba, it's okay to share my email with anyone who wants to connect. My LinkedIn is in there if anyone wants to connect through there as well, and you have the organization's link. So if you would like to learn more, I'm always happy to.
Amazing. Thank you so much. So there is one question. So if you want to address that one, how do we address white fragility around this issue of gender-based violence?
I'd like to understand the question a bit more, if I may.
Heather, do you either want to unmute?
Yeah, I'm just unmuting. Hi,
Okay.
sorry
Hi.
about that. That was a little impersonal. Hi, thank you. I really enjoyed your talk. I'm not sure if you can see me or not. I'm on a screen.
We can see you.
It's so impersonal. Oh, good. It's so impersonal to ask a question and not see your face. That was a great talk. I really appreciate that. I finished a book recently recommended to me by Dr. Sonia Anand, who I work with at Population Health Research Institute, called White Fragility. And it's a really good book talking about how we how sensitive white people can be around the cultural issues and this issue of cultural safety, where we don't talk about the cultural appreciation of your South Asian culture, but rather how do we get up to speed quickly on being culturally safe the way that you defined it? I know it's a big question.
I kind of understand some aspect of it, and I will answer it as much as I can. A lot of people feel threatened because they think that they are being accused of interpersonal racism, right?
Mm-hmm.
Well, I'm not a racist. I haven't done anything mean to anyone. What they don't understand is structural racism is different from interpersonal racism. And if we shift the conversation to structural racism, which leaves no one innocent, that leaves people feeling less threatened, and be more willing to engage with the larger issues that perpetuate racism. Privilege? I mean, I have privilege. Look at me. I'm sitting here in this comfy room talking to you over Zoom in English. This is privilege, right? It operates at something that's larger than whether I'm a racist personally. If I mean, just using bad words and being rude to people, that's not all of racism. If you shift the conversation to those larger aspects, which leaves no one innocent, makes everyone complicit, I think it's helpful. I think Justice Sinclair has made powerful, very explanatory remarks about systemic racism. This happened in Alberta after, I think, one of the police chiefs over here said, well, there is no systemic racism in the RCMP, because he did not understand what systemic racism. He thought systemic racism means everyone's a racist. But he didn't understand the difference between interpersonal racism and systemic racism. Shifting the conversation helped a lot over there. That can help.
That's great.
Maybe.
That's a great answer. Thank you very much.
Thank you so much. Thank you, Heather. And thank you once again, Dr. Mishra, for that amazing presentation. We'll move to the next session. And after that, we will have a lunch break. So the next session is Building Resilience for Future Public Health Crises. And we have Dr. Amrit Sadev. Dr. Amrit Sadev is a physician working out of Peel region with a specialized interest in vulnerable populations, immigrants, as well as technology. He completed his medical training from the University of Calgary and completed residency training in family medicine from the University of Toronto. Working out of the University Health Network in downtown Toronto, he completed a master's in artificial intelligence from Queen University, as if the medical degree wasn't enough, and works with a digital health and insurance company in Toronto, Torcor, pushing for improved patient outcomes and reduced costs to the healthcare system. This past year, he was involved in forming the South Asian COVID Task Force. This is our shot COVID vaccine campaign and works to increase health literacy in newcomers to Canada through his work with Kingston Immigration Services, a federally funded organization. He's also a member of Action Canada, as well as the Lieutenant Governor General Leadership Conference. Dr. Saddev will be addressing building resilience with a focus on immigration and visible minorities. I'm always amazed to hear how many things Amrit is involved in. So please welcome Dr. Amrit Saddev to the stage.
Thank you, Samia. Really powerful morning so far. You know, just listening to the other speakers, we all have different paths to getting here and sharing our experiences and our knowledge with everyone. I just want to thank you guys for creating this environment, for collaborating and talking. And, you know, hopefully whatever I've done helps add the conversation. And I'm seeing some themes already between what my slides are and what's already been said. I took this topic and I've kind of whittled it down a bit to focus on immigrants and newcomers. Because it's such a large topic, building resilience for future public health crises. And I took the approach of really kind of almost, you know, a little bit of what Angela spoke to about what the experience was for newcomers during COVID. And I think that's so important because you can't really build a solution or a path for resilience if you don't understand what the experience has been. So what I did is I did a quick literature review, and I got lucky. StatsCan started producing some light information on the immigrant experience during COVID, using data between 2020, 2021, early 2021 and late 2020. And this is the most up to recent data that I could find. And there's a couple of key messages that they identified, which, you know, we've kind of covered, to be quite honest with you, but this might help bring more shape to it. So we know that immigrants were overrepresented in jobs with greater exposure to COVID. So this was frontline essential workers. We know that they're also more likely to work in industries that were heavily affected, not just by exposure to COVID, but also financial vulnerabilities. So now you have a financial impact on top of a health impact. There were some remarks made by StatsCan that I thought were interesting. The efforts that immigrants have had on closing economical gaps between themselves and Canadian-born populations was starting to close. However, due to COVID, that gap has widened enormously, and you know, StatsCan believes that it can take years to get back on track, so to speak. On top of the exposure risk, the financial risk, I think this was really powerfully covered by Angela's topic this morning, was the emotional mental health aspect that was starting to seep in as well, with respect to racism, harassment, attacks, and so forth. And I'll cover that a little bit today as well. You know, there was some conversation around vaccines as well earlier. And this data, again, was around late 2020. And they found that, interestingly, immigrants were more concerned about their health and social consequences compared to Canadian-born, but less likely to get a vaccine. And we'll see if that changes as you know, our preparation and health delivery around COVID continues. So this is just putting some graphs to what we've been talking about. This is the proportion of immigrants among nurse aides, orderlies, and patient services. That should say 1996, not 1906, 2006 and 2016. So we're essentially talking about almost a third of healthcare workers in 2016 for immigrants working as frontline workers, an enormous number. This trend has continued during COVID. In July, 24% of employed Filipino Canadians and 20% of employed Black Canadians worked in this industry compared to just 14% of all other workers. These sound like numbers, but what this represents is the continued transmission risk for minorities and visible minorities and immigrants in the healthcare sector. The healthcare sector, over 25% are made up of people that belong to this population. And these are the most dangerous kind of jobs. We saw massive outbreaks in long-term care homes when COVID started. And so when we start thinking about resilience for future public health crises, we have to take into account the jobs that immigrants find themselves working in. On top of healthcare, along with that frontline role was food accommodation sectors. And this was highest among Koreans, almost 20%, Filipinos, 14%, and Southeast Asians, 14%. Now, what was very concerning was that the unemployment rate was getting significantly higher for visible minorities compared to the national rate. And this is directly related to the jobs that they held going into COVID. So Arab population, 18%, Black population, again, close to 18%, Southeast Asian, 17%. You're starting to see a trend now of a relationship between the jobs, financial impact, and I think the audience are well-versed on the associations between employment security and health security and social determinants. This is a throw-in slide that doesn't need much more to say about this, is that in addition to unemployment, the jobs they're working with are also lower wages jobs, right? So this is compounding the financial insecurity aspect. The poverty rate ranged from 27 to 32% amongst Black, Chinese Canadians, amongst Korean, Arab, and West Asian Canadians. Amongst Black and Chinese Canadians, the poverty rates reached 20%. Enormous numbers. Not being able to meet financial obligations or essential needs, that was over 40% for Arabs, West Asians, and Filipinos, respectively, compared to just 23% amongst the white population. So the triple jeopardy here is that, you know, the vulnerability of transmission, the vulnerability of financial security added to the vulnerability of mental health. It wasn't just due to, you know, living paycheck to paycheck or not being able to pay rent, afford food, concerned about their jobs, but it was also due to reports of facing harassment, attacks, and stigmas. There was a survey done, a crowdsourced survey done, where visible minorities reported that they're 3 times more likely to have a perceived increase of harassment or attacks based on their race, ethnicity, or skin color compared to just the rest of the respondents. And this was highest amongst Koreans, where 43% of respondents felt that way. Filipinos, 38%, Chinese, 31%. This is an interesting slide because it compares recent immigrants, that's 0 to 5 years established, 6 years plus for established immigrants, and Canadian-born, which represented in the gray bar. What we see is that mild symptoms of anxiety, moderate symptoms of anxiety, and severe symptoms of anxiety are all higher in recent immigrants. This is assessed by the G87 survey, which assesses essentially dysfunction in life due to anxiety. So this would be your inability to properly carry out your life roles and responsibilities, whether that's going to work, going to school, your relationships with your loved ones, sleeping, panic attacks, all that. I also thought it was kind of interesting that Canadian-born population had higher mild, moderate, and severe symptoms than established immigrants. And I wonder if that's due to a combination of social supports, housing insecurity, and so forth. We touched on this, with some of the other presentations today, which is other impacts on the immigrant's life that were contributing to mental health anguish. Violence in the home. So the light blue bar is Canadian-born individuals, dark blue bar is immigrants. Violence in the home was significant. These are asterisks represent a significant difference, so a p-value less than 0.05. Violence in the home, stress from social isolation, stress about their own health, stress about their family members' health, and even concern over civil disorder were all significantly higher in immigrants. And that's a really sad, disappointing, difficult piece of data to see and actualize here. South Asians in general reported basically worse mental health than other visible minorities during the pandemic. So this means that they reported fair or poor self-rated mental health and somewhat much worse mental health, in particularly since physical distancing began. And obviously that speaks to the social supports and constructs that our population has there. The symptoms became quite severe, like I said earlier, and generated towards moderate or severe anxiety disorder. And the last thing I've already touched on here is that it wasn't just the social separation, but the financial aspects that COVID had. I thought it'd be also important to talk about, some of the aspects it had on children as well. And, the Toronto District School Board is Canada's largest, school board. And in May this past year, the Director of Education sent out an email essentially identifying their observations in their schools, which were that South Asian students were experiencing disproportionately higher levels of crisis and concerns and anxiety, which were associated with things that are going on at home and things that are going back on in India. And this was during the third wave. I thought that was really powerful because, when Angela was talking about, this is just too big of a problem to solve for one population or one, minority group. It really requires a togetherness approach because it's everybody's being affected by this. And I thought it was powerful when, the Director of Education was standing up and saying, listen, there's something seriously bad going on right now. And a quote that helped me kind of shape this presentation was an article that was on a website called Healthy Debate. And it's by these pediatricians, Dr. Bai and Dr. Minhas. And I kept kind of thinking about, well, what does resilience mean? And this quote kind of just hit it home for me. And I'll read it out loud. More than ever, we need policies that support racialized families in breaking disabling cycles that are fed by systems that marginalize and stigmatize. Complex problems require equitable, multifaceted solutions, such as adequate paid sick days, meaningful community engagement, funding multi-generational mental health supports, and this is a place to immediately begin. And I keep going back to policies that support breaking disabling cycles, because I feel like that's what we're stuck in. That is our reality. And so I use that approach for thinking about disruption moving forward. And the reality is that this is not just an urgent issue for people in Canada, it's an urgent issue for people coming to Canada. Canada has established immigration as its policy for economic and population growth. In 2019, they targeted 285,000 people. 2021, that number increased by over 100,000 to 400,000. There are some organizations that are calling on 1 million a year. So the immigration population is only going to get larger and larger. And there is a sense of urgency to figure out, if we are going to rely so heavily on newcomers to shape our economy and shape our population, if we don't provide the policies that help them, this is going to snowball into something much bigger and much worse than it already did. Some interesting stats that came out of this were that approximately 50% of immigrants are coming from South Asia in 2020. And immigrants account for 33% of all business owners with paid staff, and 25% of workers are in the healthcare sector. So this came again from StatsCan, and it just speaks to the contribution that immigrants have to the economy, and to taking care of the Canadian population, which then also unfortunately puts them at higher risk for future public health crises. Building a model for resilience is really kind of hard. Lucky enough, Harvard started working on this this past year. And they simplified it. They made it really simple so that they can take something that's not simple and present it in a way that's really based off of 3 steps. But within those 3, steps, there's a multitude of things to get done. And these 3 steps are based off of either increasing the positive outcomes, decreasing the negative outcomes, or changing the fulcrum. And the fulcrum is represents each individual's ability to deal with our hardships. Every immigrant, every person in Canada, we're all different. We all have our own internal coping and capacity skills. And I'm going to talk to that in a bit. So the question then is, how do we build resilience? The first thing is kind of obvious. You reduce sources of stress, right? So, this can be very simple and this can be very complex. Very simple would be meeting needs like access to diapers for children, right? Formula, basic thing for children and young families. Internet access, this came up previously, if we rely on digital solutions in a world that's not connected, then you're essentially cutting out people from interaction. It gets more complicated because then you're also talking about financial security, preventing job loss, changing policies in contract work and work without contract, like Uber, where then there's lobbying and all that other stuff going on. But the urgency is there based on where Canada wants to go as a country. Second option is supporting the positive side, right? Whether that's building up more community services, which is something I'm personally and openly supportive of. Flexible parental leave they have here. They did stuff like virtual home visits, and it gets more and more complicated, such as working on unemployment benefits, stable housing, and so forth. So there's certainly levels to this. And I think we have to look at the lowest hanging fruit that can produce the best benefit and what's realistic as we move forward. This is where things get really interesting, which is strengthening core skills, move the fulcrum. I'm a big fan of this in particular because now you're investing in the person. You're developing individual skills that will be with them for life. And I think that's very, very powerful. We all need to develop our executive functioning and self-regulation skills. And we'll need those core skills as future public health crises occur. The reality is, though, basic needs need to be met before we can focus on anything else. And this is more of a long-term play. The reality is, and fortunately, there's organizations, not just these 2, but these are the 2 that I've started to work with or become more familiar with, and referring my clients to, my patients to, who basically facilitate moving the fulcrum. And I think that's very powerful. And I think this is really the way forward. These are the policies that will break disabling cycles, right? This has to be a generational shift in families, in communities, in populations, where you invest in the individual and you support that with policies that are going to help with the other aspects, paid sick days, community engagement, mental health supports, and so forth. So that is the presentation. I just want to thank CASSA again for all the work that they do. I'm a really big supporter of Samia in our group, and I'm happy to be part of this.
Thank you so much, Amrit. We have a few minutes for questions. We already have some in the chat there, so I'm going to pose the first one to you from Michael Kerr. So Michael says, I think there's a real risk in conflating immigrants with peoples of color, as this slide seemed to be doing, a visible minority in government speak, as it tends to shift the conversation to newcomer settlement and strategies and interventions and away from the color-coded inequities that you've highlighted. How do we keep the necessary focus on racialized disparities in order to succeed in our racial justice change-making efforts?
Yeah, that's a great point, Michael. It's a difficult balance because the racial justice efforts need to be and quite correctly need to be uniformed and approached together. The data that stats can it's tricky. This is a really tricky topic because the data that stats can report it on is group-based data. Now, medical and healthcare people were asking for that data for a while because we had difficulty understanding the needs of different communities. And I think there might be a position where data is used as it is helpful, and it shouldn't be misrepresented and confused for a more widespread approach, such as racial justice changes. I would use the data to help understand the needs of communities where physicians are working with certain populations, and I think that's the approach that was taken. But I think I can't answer that question to its completeness, but I would argue that there might be a place for both.
Okay, awesome. Thank you for that, Amrit. So there is another question from Dr. Mishra. How do we encourage conversations about mental health among South Asian families? It is deeply stigmatized, which is a barrier for seeking health. Amongst youth groups at my organization, it has come up that they do not dare to share their mental health challenges, such as mood disorders, with their parents, who scoff that you have it good, we take care of you. What's the big problem?
Yeah. Dr. Mishra, when I first met people from Soch, this was my thoughts exactly, right? There was an organization that was created by essentially a younger generation of South Asian people who also worked in the healthcare field that created a link in communication to children and families who needed it. These are great questions. How do you deal with stigma in a South Asian family? It's hard. There's no quick answer and there's no quick solution for it, which goes back to me investing in the individual and creating the access for that. And I think Soch has started on that. I don't, it's not over by any means, but they are an organization that is built interventions that are targeted towards this issue altogether.
Yeah, and I would like to add also to that the Punjabi Community Health Services also takes a whole of family approach when they're doing their mental health counseling. So they involve parents and grandparents and everybody. So I know Baldev Mutta himself has created a lot of content for the older generation to be able to understand mental health and what youth are going through. So maybe also look into the Punjabi Community Health Services because they've got really great content. I know Dr. Mishra, you had a follow up. I'm not sure if that you want to unmute and say it, or do you want to read it?
I just wanted to say one thing, that the youth groups that I described, they themselves suggested that they suggested in public health messaging around the topic to de-binarize the issue of mental health. So a lot of people think it's like either sane or crazy, right?
Right.
This versus that.
Yeah.
They don't see it as a spectrum.
Yeah.
That it's like health, right?
Yeah.
It can be various degrees of sick or healthy. So they thought that might shift the conversation a little bit towards more talkable.
It's what I'll be honest, it's what I'm a fan of with Soch, which is taking the gatekeeper for mental health services traditionally have been healthcare workers. What the reality is that mental health presents very differently in different types of people and with different realities. And if the gatekeeper doesn't recognize what depression looks like, what realities are for different groups, then that connection is not happening. I don't think healthcare workers should be the gatekeeper for resources like mental health. And which is why I go back to investing in the person, changing the fulcrum position as a very strong point for all these organizations that are here.
Thank you so much, Amrit, and all the attendees for the questions, and really appreciate your presentation today with us. And I also very much appreciative of all the support that we have received from the COVID-19 task force and the ongoing work that you're doing with This Is Our Shot campaign. So we are now at our lunch break. So we are going to begin right at 12:10. So you have about half an hour. And again, just like yesterday, if you want the real summit experience, feel free to grab your food and come back and network with the attendees and the speakers from this morning. I know we had a really powerful panel this morning with Angela, Amrit, and Dr. Mishra. So please connect with them through Feedloop and network with other attendees. And we'll be back with the afternoon sessions, which includes Dr. Amrit Arya, Samia Abdi, Sabrina Miller, and Noshin Hussain. Thank you, and we'll see you in about half an hour.
Hello and welcome back. It is now time to introduce the final plenary speaker for Building Resilience for Future Public Health Crisis. Dr. Amit Arya is a palliative care physician who works in long-term care homes. Dr. Arya serves as a lecturer for the Department of Family and Community Medicine at the University of Toronto and assistant clinical professor for the Department of Family Medicine at McMaster University. Dr. Arya holds multiple leadership roles at the national, provincial, and local level and was awarded the 2020 Award of Excellence in Social Responsibility. Recently, he co-founded Doctors for Justice in Long-Term Care, a large coalition of over 1,000 physicians and researchers advocating for an overhaul of the long-term care system in Ontario. Dr. Arya will discuss the transformative changes that are urgently required for long-term care. Please welcome Dr. Arya.
This picture is actually from one of the many long-term care homes that I worked in during the COVID-19 crisis, where I would go into a long-term care home as part of a hospital rapid action team. And we would actually see over hundreds of people who were infected with COVID-19, health workers who were run off their feet, not being provided proper PPE, and lack of action actually from all levels of government. So just very quickly, I don't really have any disclosures or conflicts of interest. I always throw that in as a physician. So just a little bit of background, because not everyone might be familiar with who lives in long-term care facilities and why people end up in these facilities in the first place. So these are really places where people go who in general have advanced life-limiting illnesses. So illnesses like dementia, congestive heart failure, COPD, these are incurable illnesses. And often when the system is not designed to look after people in home, then they end up in these long-term care facilities. And I'll talk a little bit about that. But essentially we can think of it as analogous to maybe the initial phases of life, like birth or childhood. This is where people go for the last phases of life. And that's where the annual mortality rate in long-term care homes is 27 to 52%, so very high. And the average life expectancy is 2 years or less, which brings in my work as, of course, a palliative care doctor. So, of course, we know that COVID-19 has not impacted everyone all the same. And long-term care homes, or people who live in long-term care facilities, have actually borne the brunt of COVID-19 by and large. I can add sort of a little bit of more information that at one point in time, Canada actually, I think about 81% of the deaths in the first wave were actually in long-term care facilities. And even now, Canada is really by and far, the leader in terms of the proportion of COVID-19 deaths in long-term care facilities compared to all other OECD countries. So we know very well that COVID-19 doesn't impact everyone all the same. Actually, we know that 18,000 deaths so far out of roughly a little over over 27,000 have actually occurred in long-term care facilities and retirement homes. As somebody who works in this sector very regularly, I'm very afraid about what's happening in the public discourse right now, where because vaccines were kind of delivered in the, through this, the end of the second wave and the third wave, and we were dealing with the Alpha variant, vaccines provided fantastic, protections for the people who live in long-term care. But now with the fourth wave and the rise of the Delta variant, we're starting to see the deaths creep up again. In fact, I can tell you just 2 months ago, there were only 10 long-term care homes and retirement homes under COVID-19 outbreak 2 months ago. And now there's 210 across the country. So this is starting to become an issue again. And unfortunately with vaccines, we've forgotten about the underlying structural inequities and, concerns that, are part of this broken system. And I have not seen, even with a federal election, I've not really seen anyone with the courage that will sort of overhaul the broken system that is our long-term care system, that is our elder care system. So yeah, I put in this slide because I think this is important. We talk about long-term care reform, but actually I don't think this is a system that really can just be reformed. We don't want sort of transformative changes or we don't want small changes to the system where people look at one aspect and they say they're going to fix staffing or they're going to pay workers better wages. There's a much bigger problem. Of course, those things are needed, but the whole system actually needs to be redesigned. And I'll add some information about this. Of course, I can talk about this for a long time, with this being my passion and my area of interest, but you might not know this, but the long-term care system was actually, it actually originates from the penal system and not from the healthcare system here in Canada. And another point that I can add is that, really what's happened in COVID-19 has just shone a light on what's been happening for decades in the long-term care system and in the elder care system. And really it is based on, systemic discrimination on multiple variables: ageism, ableism, sexism, and racism. It exposes greed and austerity in our public health system, where we think about like we supposedly have universal healthcare here in Canada, but in fact our system here in Canada, we have the least universal healthcare system, which doesn't cover medications, for example, doesn't cover dental care, also does not cover elder care, and people will not receive the care that they deserve and they need at the time that they need it. And that's what the system is reflective of. And it's also reflective of, how we have, a way for, at many points in people's lives, when people are suffering, people are neglected. And, for most of the people who live in long-term care, not all, once again, these are older adults in their last phase of life, we've separated them away from society. And we haven't really valued that as actually, a time when people should be getting, the life they deserve and should be provided, actually the best care and should receive a good quality of life. So I'm now going to move on. After that part of the conversation, I'm going to move on to speaking about what are some of the solutions that we need to look at and how should we, be addressing politicians and health authorities of all levels to make those changes. So of course, I'll add, as someone who has these conversations every day with patients and families, I've yet to meet someone, honestly, even before COVID-19, who wanted to actually be in a long-term care facility. Honestly, nobody wants to end up in long-term care. And especially after what's been exposed with COVID-19 and the horrific conditions, I can tell you that people are just absolutely so terrified of ending up in long-term care. And by and large, that is absolutely, that's the right sentiment. I'll be very open with you. I wouldn't want my loved ones to end up in long-term care facilities. And when I actually speak to health workers who are in long-term care, they express the same sentiment, very sadly. So what this means is that we need better home care. And you might be surprised to hear this, but actually in Canada, our whole model of looking after older adults, people with disabilities, is very flipped and is very warped. So what does that mean? Actually, 81% of the spending in Canada goes toward these institutions, these long-term care facilities and buildings. And only a very small proportion, around 20%, goes towards home care. And other countries are completely opposite. So for example, other OECD countries in like Northern and Western Europe, they generally provide around 2/3 of their funding, or at least half of their funding, towards home care. Denmark is thought to be the gold standard. In Denmark, really about 2/3 or more, even 75% of their funding goes towards home care. And what that means is actually they have not even needed to build any new long-term care facilities over the last, I believe, 2 decades, in spite of the fact that they also have a rapidly aging population. So I think that we need to actually pour in money in home care, and that will actually allow for people to actually live where they want to in their own homes. Of course, along with, when we speak about home care, that actually means that people have to have homes. And, that's obviously, a big issue. And I'll add that people experiencing homelessness in that demographic, seniors are actually the fastest growing demographic of people experiencing homelessness. So we need to provide secure, affordable housing to everyone. Housing should be a human right, especially for older adults. And providing geriatric and palliative home care, providing better primary care will allow people to remain in their homes where they want to be. Getting a comment with, from Amrita Mishra, thank you so much for posting this. The funding available to MPOs and NGOs for seniors programming is always incredibly short-term and abysmally low. So thank you for mentioning this. Example, $25,000 for 1 year with no more than $6,000 for staff salary for the New Horizons Seniors Program. I've definitely heard of this as well, Amrita. Thank you for bringing this up. Ageism is intimately woven in with those funding plans and policy agendas. And I cannot agree with you more. I would add that in addition to ageism, a lot of this is ableism. That is really the intersecting sort of a focus of discrimination in long-term care facilities, because these people who end up in these facilities or people who end up requiring home care are not people who are sort of healthy older adults who can drive around and fend for themselves. These are people who are very weak, often spend most of their time between a bed and a wheelchair, and are in declining health, as I mentioned before. So I think, I talked about home care. Definitely, I think that has to be a focus. And sadly, that's been neglected in this conversation around COVID-19, because unfortunately, home care, or fortunately, it was not impacted actually as much during the pandemic. It was obviously not a congregate setting, and that's why. And in fact, if you lived in home care, your chance of dying from COVID-19 as an older adult was 74 times lower. But we need to talk about it. And then at the same time, we need to talk about how to change our long-term care facilities to be more home-like. I mean, honestly, we call them long-term care homes. I don't. I tend to call them facilities, because they don't look anything like what anybody would consider to be a home. They don't smell like a home. They don't feel like a home. Staff are coming in uniforms. It absolutely does not look like anything like a home. What we saw very sadly during the COVID-19 pandemic and the first and second waves is that many of the older for-profit long-term care homes had what they called older design standards, literally from the 1970s. And in 1998, they were given sort of a notice to upgrade, and they didn't upgrade them, and yet their licenses continue to be renewed. And that was deadly during the pandemic. And what it means by these older design standards is that you have 3 or 4 people living together in a room. Obviously, that's horrible for people's autonomy and privacy. So there's so I would ask you, who wants to live in a dorm room type of environment with 3 or 4 other people? So that obviously is very bad. And sharing a room with 3 or 4 other people and then having one bathroom would be extremely deadly during a pandemic. It'd be very easy for a virus which is airborne and spreads like cigarette smoke to spread very rapidly through the facilities. And I'll add one more point, is that the people who lived in those 3 or 4 bedrooms were undoubtedly people who were socioeconomically disadvantaged, because you can pay extra money to get like a double bed room with 2 beds, and you can pay even more money to get a private room. So the people who could not afford to pay those extra fees, which I often see. I see people who live with disabilities, people who experience homelessness, who are in long-term care facilities, along with many other illnesses, who sadly ended up in those 3 or 4 bedrooms and were much more likely to die. Yep, we've talked a little bit about staffing, and we undoubtedly have had a staffing crisis. And we know that if we improve the working conditions, which includes improving, really this is the story about labor rights and how labor is a determinant of health. And that's really been shown through the COVID-19 pandemic in long-term care facilities and in elder care, to be honest. So, I have these points up on the slide. You can read them for yourself, but I'll tell you that, most of the people who work in long-term care homes, 2/3 of them are racialized people. Many of them are immigrants to Canada. They don't speak English as a first language, and they have absolutely been left for dead through the pandemic. Even with vaccines, really the focus was on getting them vaccinated, which is so important to protect them and to protect their families and communities and to protect the residents, undoubtedly. But we haven't really dug deeper, and we haven't looked beyond, what to do beyond vaccinations. Whether it's the residents or the health workers, they deserve so much more than just a shot in the arm. We need to treat the health workers with dignity and demanding respect, that starts with sort of providing them proper PPE. I can tell you that I still hear from long-term care facilities, you might be shocked to hear this, and all of these are for-profit long-term care facilities, that they don't have enough PPE, they're not trained on how to provide PPE. And an example of that is N95 masks. They don't have N95 masks, they're not provided rapid testing. These are obviously potentially deadly problems during a fourth wave. People who work in long-term care facilities, we've talked about, I mean, there has been a national discourse, I feel, around PSWs who actually, provide 90% of the care work. And there's been some temporary raises provided, nothing permanent, nothing looking at a living wage, giving people single site work. And we still have agency staff who are not in that sort of rule, who are exempt, are paid much less and work in multiple facilities, which is bad for the residents and it's bad for them. So we need to improve the working conditions. There was a campaign in 2018, which was the 6-minute challenge. And that challenge was basically, it showed that a PSW at that time, and actually our staffing levels have gone even lower, a PSW actually only had an average of 6 minutes to get someone ready in a long-term care facility for breakfast. And this is somebody who's like often in their 80s or 90s with dementia, who's very frail, can't even get up on their own. So if we can't get ready in 6 minutes in the morning, how do we ever expect a PSW to do it in long-term care? You need to have this is a sort of human resources crisis where the federal and provincial government needs to take immediate leadership to have trained health workers on the ground, and once again provide them the supports, the dignity, and the respect that they need to actually stay and be retained and work in this important sector. Part of what we hear about long-term care facilities and part of the discourse is that, well, anybody can go in and work in a long-term care facility. And, we know the military, unfortunately, had to go into many long-term care facilities, and they had reports which exposed many of the horrific conditions. But I'll add a little bit more to that, is that actually this is very highly skilled work. And, you cannot send anybody into a long-term care facility who does not have the proper training. I can share with you, just a month ago, I was talking to a nurse practitioner who had been thrown out on the front line of a long-term care facility, who had experience for the last 15 years in pediatrics. And she was just put out there with no training in geriatric or palliative care at all, no training about how to look after people. And that's absolutely unacceptable. I can tell you, I work as a palliative care physician. I can't just go up to labor and delivery like today and just start like delivering babies and looking after people who, that the obstetricians do. There's no way I can do that. I can't take a shift in the emergency department right now because I'm not trained as an emergency physician. But somehow in long-term care and even in home care, this is the issue, where you have people who do not have the skill set. And that speaks to how in nursing school, in PSW school, in medical school, geriatrics and palliative care are not even required rotations, even though our population is aging very quickly. So that obviously needs to change. Yeah, I do feel that one of the ways, and I'll just quickly mention a note on this, one of the ways in which we can better support long-term care facilities and people at home is through virtual care. So often the story before COVID-19 is that people had to physically go to their specialist in order to receive care from a specialist, and that should not be the case with virtual care. I think we can all agree on that. We've seen how family caregivers are so essential to supporting people who live in long-term care facilities, and they by and large have been neglected. For the first and even in the second wave, sometimes we saw people who were staring through a window who were locked out, and that's absolutely, I think it's a gross human rights violation. It was done in the name of infection control, but we know that infection control failed anyways because so many people died, and there was a way to safely train, and still is, safely train family caregivers to be allowed into long-term care facilities. Now, by and large, people are allowed, but that access is still precarious. Facilities can actually choose at any time to lock people out if they feel that there's an outbreak situation, and we're encountering that with the fourth wave, and that absolutely should not be the case. So we need to do a lot more to support family members, including recognition and compensation. We've obviously seen there's an issue with transparency and accountability. I can tell you from, once again, somebody who worked during the COVID-19 crisis, that the reports that we heard through the military were absolutely not unique, actually. The military only went into, I think, 5 or 6 long-term care facilities, but there were many, many other long-term care facilities where the military did not show up. I can tell you that I spoke to my previous hospital's chief of staff about those facilities, and they tried, but the government did not respond. And we have to ask ourselves why is that the case? Why do we not have more oversight? We have inspections in long-term care facilities that actually, even if they report actually horrible failures in infection control, or horrible neglect, or even sort of abuse of the residents, they can't actually even take any action towards the facility. So those inspections have no teeth. And that's obviously a problem, right? Where we don't need to see all these reports again and again. We don't need to see all these task force. We don't need to have all these exposés. Like, this is sort of a slide from W5. CBC Marketplace has done multiple shows on long-term care and what's happening inside long-term care facilities. We need action to actually protect the people who live inside these facilities. And once again, long-term care in Canada and in Ontario, and also elder care in general, home care does not fall under the Canada Health Act. It is not publicly funded. So Canada Health Act generally includes physician care and hospital care. And other than that, you're kind of out on your own. And unfortunately, here in Ontario, we have the highest proportion of private for-profit long-term care facilities, well over 50%. And I mean, that's absolutely abysmal. We know that these facilities provided a poor standard of care even before COVID-19. And I mean, honestly, this is just dangerous for people who live in these facilities, elders, people with disabilities. It should not be allowed. The death rate in these for-profit facilities was far higher than those that were run by the government, or those that were run by not-for-profit corporations or groups. So absolutely, this needs to be changed. And we absolutely have the solutions on how to do this, but we need political will to make sure that this starts to happen. And I absolutely think that we need to incorporate long-term care under our universal healthcare system. We need to incorporate home care under our universal healthcare system, and we need to stop the austerity measures that are unfortunately applied to this sector. And I sadly feel, as Amrita has also mentioned, around ageism, and we talked about ableism, it's unfortunately because the people who are living in these facilities, the people who are suffering and are not receiving the care, I truly feel that they can't contribute to the economy anymore, very sadly. So they're devalued, they're dehumanized, their health workers are dehumanized, and instead of providing people with the care and the life they actually deserve, we're trying to actually generate profit for shareholders, pay executives millions of dollars, and that's, once again, should not be allowed.
Amazing. Thank you so much, Dr. Arya. You brought in so many amazing points in the short time that you had. I really appreciate it. And just wanted to say that really appreciate that while you're on duty at the hospital, you're taking your time out to be with us today. Really one of the heroes, of the true heroes of this pandemic, and really appreciate your advocacy throughout this time. And we hope that we can work together to bring about some systemic change in long-term care. We have a few minutes for questions for Dr. Arya. If anybody would like to unmute and ask your question, or you can pose your question in the chat, then I can ask Dr. Arya. But I know the really moving presentation and a lot of really great points made.
I can add one more point. Obviously,
Yep.
There's a lot to speak about here, and it's a very complex system. And as I said, many intersecting layers of discrimination are inherently woven into how the system is just made. And it's a fundamental design flaw. But another issue that is relevant for us all speaking on this talk is that you might be surprised to hear that only 8% of long-term care facilities in Ontario are what we would call culturally specific long-term care facilities. And that's obviously a problem, right? So we see elders who have dementia, people with disabilities, who end up in homes where they don't celebrate their religious holidays. Nobody speaks their language. Nobody will cook food that they're more likely to eat. And very sadly, there's evidence that obviously people in those situations actually die quicker. It's very dangerous. So that is the real scenario.
Really great point. I'm just checking if I'm unmuted, but I'm okay.
Yeah. So I do see
first,
2 questions.
Right.
Yeah.
So do you want me to, I can just read it out for the audience here. Where are the human rights commissions amidst all of this? So that's the first question from Dr. Mishra.
So I'm not completely aware about where they are. I know that, you might have seen in Ontario, there was a commission appointed by the government, which did say some reasonable things, but honestly, I think there's nothing new in terms of what they said. because we've had, like, this has been a problem for decades, and once again COVID-19 just shone a light on the conditions in long-term care and exposed the cracks in the system once again. So we don't need more reports. We don't need more task force. We don't need like just sort of deflection from the governments, which is truly what it is. We need somebody to take action and treat this issue with the urgency that it is. I mean, when I'm as a physician hearing from my patients on a regular basis that they have to wait 30 minutes or 40 minutes for a PSW to arrive to take them to the bathroom, and then they're forced to be in a diaper, or there's not enough, they're still hungry and they can't be, they don't have enough time to feed them. And once again, the family members are stressed out and they're sort of burnt out because there's not enough support in the system, and they have to go in and provide hands-on care every day. I mean, this is an issue that cannot wait. And then, sorry, there's one last thing, one last question. What is your approach to standards and for-profit providers in this space moving forward? Or so I have a very clear stance that, I mean, we need to start phasing out for-profit care in long-term care. We recently had a federal election, and I only saw the NDP and the Green Party speaking about this. And honestly, this is not a partisan issue because we're all aging, or we have loved ones that are aging, our parents and grandparents. And I'll add that Canada actually, this is a critical year in terms of our aging population, because 2021 is the age when boomers, our largest demographic group, turns 75. So the demand for elder care services, which, as I said, preferably should be at home or should be in home-like settings, is only going to exponentially grow. And once again, this is actually our moment to completely overhaul the system and make drastic changes that have been needed for decades. I can quickly add, if it's appropriate to put it in the chat box, there was an opinion piece that I wrote for Policy Options, which was written from a federal lens on what can be the first steps about how to make this happen. Because as you know, when we speak about investing in our public system, often in our healthcare system, sadly, the first question we hear from reporters is, well, oh, how are we going to pay for this? Right. And honestly, I find that's a very wrong question, because when we talk about, sort of investing in the military or, other aspects of our healthcare system, nobody asked that question at all. So this is something that's absolutely for the public good, and it can be done. And I'll just finish my last sentence. The reason it can be done is because actually, you might not know this, all long-term care facilities, whether they're for profit or whether they're funded by the government, are actually subsidized by us. Our taxpayer dollars go to subsidizing all of these facilities. In the same way, we're already paying our money towards these facilities, but in some of them, the ones that are private and for profit, they actually pay their health workers less and they keep them poor. They're more likely to hire part-time health workers. They're more likely to, obviously, they're not going to upgrade their facilities, and they will extract every sort of bit of money that they can to pay their shareholders. Whereas in the not-for-profit and the government-funded facilities, they invest all of that money in care. So we are already paying all of our money as taxpayers towards the long-term care system. So it makes sense that our money should obviously not be going towards shareholders or CEO, bonuses, should be going 100% towards care. That's kind of the bottom line. And that needs to be a big issue for all of us. Right. So I'll paste in the chat box this, once again, this opinion piece that I just co-wrote for Policy Options.
Amazing. Thank you so much. That's brilliant. And definitely we'll read into that. So that does conclude our session with Dr. Arya. I know that it's very engaging discussion and a lot of really great points. But again, if Dr. Arya is open to communicating with the attendees through the networking options in FeedLoop, you can message Dr. Arya directly if you have any other questions. We are going to move to the breakout sessions for the afternoon. And we've got, again, a great set of speakers that will be presenting in the breakout session, and then we'll be giving an opportunity for the attendees to participate in discussion. So our breakout sessions will include data collection and decision making, which will be led by Senior Program Specialist of Public Health, Ontario, Samia Abdi. Effective communication strategies, which will be led by co-founder of the Vora Miller Foundation and the South Asian Health Network and founder of the Unambiguous Science, Sabina Vora Miller. And finally, a framework for community engagement, which will be led by the researcher of Public Health Agency of Canada, Nosheen Hussein. So if you can just wait a few seconds while we place you in the breakout sessions and start those sessions. And again, we will have two of CASSA staff introduce themselves as facilitator and note taker. So after the breakout sessions, we will come back here in the plenary and do a report back session. And if I can ask all of the note takers to keep in mind that you will be doing the report back for 5 minutes when we come back into the main room. So I'm going to start the breakout sessions. And if you could just click join so that we can have you in the appropriate rooms, that would be great. There we go. Alrighty. The host had muted me. Thank you, everybody, for joining the breakout sessions. I was just saying that I apologize if we ended the session right when you were engaged in a very powerful conversation. I know in our session we were. It's always really annoying when that happens, but this time I didn't have control over it, so I will blame Madiba for that. So we are going to our report back session, and so the note takers for each session, if you can prepare to unmute yourself so that we can do a quick report back of what you heard in your session and what were some of the takeaways. So the first one is Khalud from the Data Collection and Decision Making Group Breakout.
Hi, everybody. Sorry, apologies, I can't turn my camera on. My laptop's giving me some problems. We had a pretty rich discussion in our breakout session. Samia made a lot of comments generally about like what data collection has meant and what it needs to look like and what kind of steps might we take to consider how to improve data collection that will actually lead to better actions for communities that center community needs and make sure that that data is not just kind of living in the ivory tower of the university or whatever institution, but is actually informing how things are being changed on the very local level. So I'll try, there was a lot, so I'll try to go over a few key things that I picked up on. The first thing is that I think, it was Samia Abdi. The first thing was that Samia was reiterating the importance of data collection, that although that often the people who might be leading it in certain settings might not be putting communities at the center of it, and there are improvements that are needed. Data is very important to actually understand why inequities exist and how they're manifesting in different neighborhoods or in different communities. And they also help us understand the different nuances of the community and not like completely homogenize or stigmatize an entire community. So that was a really important takeaway. And the other thing is that while that is important and it is a thing that should be pursued, unfortunately, because of long histories of colonization, as well as very intrusive forms of data collection, a lot of communities are hesitant towards people researching on them without their involvement in a way that's that's informed by grounded consent. So that needs to be kept in mind when people are doing any sort of project that involves data collection. So, for example, one of the things that should be thought about is who is collecting data and who is managing it, and are they being sensitive to the various culturally appropriate needs that might be different from one community to another, even if they might be from the same racial background. There's a lot of different factors that need to be considered, and that needs to be part of the plan. Samia very helpfully talked about two different approaches. One are the OCA principles from Indigenous communities that came out, and that kind of emphasizes that control over data should always lie with the community, as well that it needs to be collected in culturally appropriate ways. She also highlighted the roadmap or like the principles sort of put forward by Black health leaders in Ontario, and they encourage people to think of four main principles when collecting data. So engagement, governance, access, and protection. Engagement must be continuous from the beginning to the end. Governance means that decision-making on how, what, and how must be community-centered, and access means everyone should have access to the data, and protection means that data must be done in a way that protects communities and individuals. After that, after Sangya's remarks, we kind of had a group discussion about different things people have noticed in terms of data collection. One of the things that was highlighted by Dr. Amrita was regarding how Western approaches to data collection are often very different from other communities' approaches. So, for example, her own experience with community research in Indigenous communities showed that people were actually much more willing to engage in conversation if oral consent was conducted, not written consent, and when, you know, for example, even the doors were not locked and it wasn't a focus group that was so mechanical and bureaucratic, but more so community oriented and centered and just like more of a conversation. So those kinds of considerations that are trauma informed approaches and are really culturally appropriate and sensitive must be considered. We ended on thinking about solutions that people could take practically to actually improve their data collection practices and make sure that this important exercise continues. So some of the solutions that were put forth are things like, for example, having, when people are trying to access information, they should have culturally appropriate ways that cater to their needs. A lot of time when data is collected, it's done so without putting it into context, and that leads to people's hesitancy in terms of participating in that research. So there has to be a way to contextualize that data collection. An important thing in that regard is that the staff must be trained in the way that they understand that context and the importance of the data collection, and they should be comfortable with the data collection and the questions themselves, so they can engage with community members in a very meaningful way rather than a mechanical here's a question, what's your answer sort of way. And in addition, you know, it should be effective and there should be no bottlenecks so that it's not stopped midway, leaving community members hanging. Of course, in terms of actually readjusting approaches, one of the suggestions is that we should have community leaders or trusted community members who understand the context and the goals of the data collection, and they can actually communicate that to community members better, bridging the gap that might exist between researchers and community members. And one of the other suggestions that was made was that we should be considering a reversal of flow of knowledge so that community leaders and members are the ones actually teaching researchers or telling them about their experiences, whether that be in the institutional setting or outside, instead of it being the other way around all the time. So those were kind of the big takeaways from what I understood from our session in terms of just improving our ethics around data collection and really going outside of the bureaucratic boxes that researchers are put into when collecting data.
Awesome. Thank you so much, Khulud, for that detailed summary of the session. You did a really great job. Next, we have Cynthia Saxena, and she is going to be recapping the discussion from the Framework for Community Engagement breakout session.
Thank you, Samia. We had a really great discussion, a really great presentation by Nusin Hussain, and she talked about the tools for community engagement during a public health crisis. Specifically, we talked more towards COVID. So first, we sort of talked about what the importance is of having community engagement tools, because what they do is that usually all of this responsibility is given to large institutions, but they usually have gaps and they sort of fail marginalized folks in feeling supported during a public health crisis. So the point for having community engagement tools is that it supports and amplifies community needs and experiences by racialized communities. In a way, it also fosters advocacy, activism, and direct action for key priorities to build collective and individual resilience, and really just gives a voice and gives a way for marginalized communities to advocate for themselves within this huge, large institutions. It also guides the direction of equitable health and social response as we move into COVID-19 planning, response, and recovery. So the COVID-19, whatever planning is, every community has their own needs. Every community has to be um, has to be sort of reminded about the vaccinations, about the health crisis in a different way. And that's why community engagement tools are very much required. One of the examples that Nassim gave, which was great, was a tool called Photo Voice, which it's almost like a it's like a picture platform, and people would post their pictures and write a little bit of a description about. So she gave a great example of a student who had posted a picture of their homework and talking about how they just have so much homework to do. They don't even have time to have dinner. They need to like drink a glass of milk instead, and how it's affecting their mental health, and it's a big stress for their lives. So through Photo Voice, communities can engage youth in this arts-based sort of research method. It also engages youth and increases their knowledge about STEM and increases their awareness about STEM. It goes beyond lifestyle narrative and centers conversation on the social determinants of health. So this is something that's been used widely in the US for positive change among Black and Latinx community. And it also helps with South Asian communities because South Asian community is disproportionately affected by heart disease and diabetes. So instead of criticizing the diet or lifestyle of the South Asian community, this is much more of a positive, much more of a sort of a community engagement tool, which shows them what a healthy lifestyle looks like, what healthy diet looks like, instead of having it done through a very large public institution, and which can just be more of a which can just be more critical and not come off that well. This is more of a community, and it just helps get the message across much better. It also helps them. The photo voice thing also helps people record and reflect their community strengths and concerns. It promotes critical dialogue and knowledge about important issues through large and small group discussion of photographs. So it's also not just huge, sort of text heavy like documents that people usually don't really go through. This is much more of an accessible form of even for people to upload, since it's only pictures, and for people to even see it and understand it. They also are connecting with policymakers to come onto that platform and to see what the needs of the community are, and to reach out to the community in a way which is so much more accessible. The other tool that she talked about was Reconnect, which is a navigation platform. And individuals and communities who are vulnerable to COVID-19 have identified challenges in navigating the overwhelming volume of resources and services in the GTA. During the lockdown and everything, we all were on the news. There was a lot of knowledge being thrown at us, a lot of directions, a lot of recommendations from all around the places. Plus, like as yesterday we talked about another group about disinformation and misinformation. There was way too much knowledge. So what Reconnect is, it's an interactive web-based tool which allows users to locate available services and supports in the respective communities. So some of the resources that are available through that tool, which makes it much easier for a lot of people to access, is things like mental health, or even just essential tools. Essentials, like where to get essentials, any mental health support they need, any sort of medical appointments that they need. So the Reconnect tool is just an easier, more interactive tool for people to really go when they're just overwhelmed with all the news being thrown at them through COVID-19 and other public health crises. Another one that she talked about was the South Asian Allyship Network goals, which is the network is a way to educate the South Asian diaspora on Canada's racist history and ongoing systemic injustices by engaging in conversations within spaces that we hold and collectively confronting anti-Black and anti-Indigenous racism. So it's also just a way to educate the South Asian community about what are sort of the issues and systemic racism and other issues that other marginalized communities face, specifically the Indigenous and Black community. It also, the network supports, disseminates, and amplifies community-led research that reveals and adds to the existing body of evidence on the systemic discrimination. And it also, again, fosters advocacy and activism and helps sort of the South Asian community understand how they can support the fight for Black and Indigenous liberation. And finally, she talked about the webinar and online discourses, how a lot of webinars, she gave like a little pictures of the webinars that have been occurring. And it's just a great way for people to really open up the space and for having discussions, for connecting with other in the South Asian diaspora, in the South Asian community, and talking about issues that not only affect us, but also on how we can help other marginalized communities and empowering them. So that's been a great tool. For discussions, we talked a bit about how this community engaged approach is really needed to be embedded into health equity into the COVID-19 planning, response, and recovery. And we spoke about the importance of it, which is because if you don't do that, people, and you only let large institutions take these decisions, there is an issue of some people being left behind. And also marginalized communities have different needs, they have different requirements, and that a large institution cannot really follow all of it. So all the planning, response, and recovery needs should be informed through also the realities and experiences of those most directly and indirectly affected uh, by these really real systemic health inequities and disparities. So a community-based approach is what is needed for a full holistic approach. And we also kind of got into what strategies and policies that we can have, which would elevate community voices at decision-making tables. So what we can do is tap into networks and groups that we already have, so sort of like the South Asian Allyship Network and other networks such as those. And we can also just tap at networks in schools, at our workplaces, at community centers, at our religious places. And it's really important to reach to people directly. We don't really need these huge bodies making policy and strategy decisions. We need to have our grassroots community heard in these big decisions as well to make the entire policy just so much more effective. And someone did raise the issue of that because of COVID, people are sort of at home these days. So how do you reach people? How do you reach your community? And how do you identify that voice these days with people at home? Which is definitely a struggle. And this is something that we need to really figure out what our space is now that everybody's at home or for whatever the future is. And how can we bring together people? Because we really need small grassroots communities. We need the marginalized communities to reflect their voices, to advocate for their voices in when all these large bodies are making decisions about public health equity. So yeah, that was about it.
Great. Thank you so much for that, Cynthia. And last but not least, we have Sakshi from the Effective Communication Strategies breakout session.
Yeah, thanks, Samia. So I was in the effective communications breakout session where Sabina gave a wonderful presentation on communication strategies and like how these communication strategies should be embedded in certain mindsets and certain priorities. So there was a lot of talk that started off surrounding vaccine hesitancy and talking about like where this is rooted from. So Sabina talked about the fact that vaccine hesitancy itself is a spectrum, that there are different types of hesitancy and there can be different reasons for it. So it's important to first acknowledge that and understand where this hesitancy is coming from. So she talked about several different types of hesitancy when you can have either like extreme anti-vaxxers, you can have general hesitancies, or you can even have just people being unsure of certain ones or accepting all vaccines. So there's really this entire continuum of vaccine hesitancy, and it's important to understand that before implementing any sort of communication strategies or knowledge mobilization strategies. So one of the big reasons for vaccine hesitancy in South Asian communities and in several communities really has been the distrust in government and healthcare systems. So as we know, Canada has had a shameful history of experimentation, discrimination, and racism that's built a lot of distrust in the government. And so that can in turn cause COVID-19 to further disproportionately impact certain racialized populations. And we've also seen that there's been really little done by the government to actually rectify that or address this issue. So now when we talk about building vaccine confidence, Sabina talked a lot about how it's important that we're not dismissive of fears and misconceptions around vaccines. Instead, we should try to understand what these fears are rooted in, making sure that we're not blaming, shaming, or drowning people in complex jargon, because then that's just going to stray people away further from things that might not be that easily understood. And so that just doesn't help the vaccine misinformation issue. So things to do, things that Sabina mentioned was being empathetic, respectful to others who have these misconceptions or who have hesitancy, having an open, judgment-free conversation with individuals, and being transparent and using credible sources to provide information or even make that information available. So she talked about the fact that it's not important for you to know everything about vaccines, to know all the information that's out there, but instead you could even be aware of resources that are reliable and turn to those instead. So instead of a one-size-fits-all approach, a lot of strategies that Sabina's used were more tailored approaches that were targeting particular concerns and particular communities. And by tailored approaches, this is really surrounding making sure that you're culturally sensitive, having various language formats to the information that you're disseminating, so that you're really able to reach these different types of South Asian communities through the platforms that are most connected to them. So some of these platforms would include WhatsApp, ethnic radio channels, ethnic TV channels at prime times. And that is one of the ways that we can build trust and build these relationships with the South Asian communities. So another strategy after that that was mentioned was partnering with other BIPOC organizations to share materials. And just by doing this, we can also hear from a greater variety of community members and have more of an input that can then strengthen the approach that is being taken. So these were just some of the strategies that were discussed to increase uptake in the South Asian community. So one of the ways Sabina mentioned doing this was through partnering with some South Asian community centers and other local organizations, where she implemented a project. And it was actually an interesting fact to me, and really nice to see that vaccine uptake had increased by a really large percentage through these knowledge mobilization and dissemination strategies. So after this, we had a discussion that really talked about how we could frame this outreach. So Sabina mentioned that we could also frame this outreach with risks. We all know that there's everyday risks in our lives, but trying to really bring the vaccines into that picture of our everyday risks that we face, and making it a little more normalized and less scary to the public. And then other strategies that were discussed were how efforts can also be taken based on age groups, so adults, older adults. And Sabina mentioned how she also on the side has strategies for targeting younger adolescents through social media and current trends, which are best tailored to them. So again, circles back to the approach of making sure that communication strategies are tailored to the concerns and the types of community members that we are trying to reach.
Awesome, great. Thank you so much, Sakshi, Cynthia, and Khulud, for those great report back. And I'm sure that there was a lot more discussed, and it really sounds like you had enriching discussions. So this actually brings us to the conclusion of our Health Equity Summit. But before we end, again, there is another feedback survey that should come as a pop-out on your screen. It says, please take a few minutes to complete the survey. And again, keep in mind, this is for day 2 of the summit. The day 1 feedback survey was completed yesterday. So if you can take the next 5 to 6 minutes to complete this, that would be really appreciated. If you don't see it on your screen, what you can do is on the main screen on feed loop, where you see the video, on the top bar where there's a search function, on the same bar there's a check-in survey. So if you click that, that will take you to the survey, and it just will take you less than 5 minutes. And if you want to be really detailed, maybe 6 to 7 minutes to complete complete. And again, these kind of surveys will really help us to plan for future events, not just the Health Equity Summits, but all of our future events here at CASSA. So as you're completing that survey, feel free to take your time. I wanted to thank everybody, our speakers, our panelists for the breakout sessions, our note takers, our facilitators, and of course the star of the show, who prefers to stay off screen. So Madiba, I did ask her to take on this role, the front-facing role, and not let me do all the talking, but she is a very humble person and prefer to do things from the background. So thank you, Madiba, for everything and for putting out an amazing summit. You did an amazing job, and I'm sure all these speakers and attendees can attest to that. So thank you once again, and please stay in touch if you would like to again touch base with any of the speakers. We should have this page from FeedLoop still up for you to connect with the speakers or other attendees. Please feel free to do that. Or if you want to connect with CASSA directly, then you can connect with Madiba, and you should have her contact information. And we can definitely touch base and see if there's ways for us to collaborate and to work together in solidarity on some of the things that were mentioned throughout the summit. So thank you everyone once again. Please don't forget to fill out the survey, and I hope you have a great rest of your day. Thank you. Take care.